In the previous class, we have read about the metabolism of the drugs. We are continuing about the pharmacokinetics of the drug. The main four pillars, time and again I am saying, absorption, distribution, then metabolism and then elimination of the drugs. Already we have covered about the absorption of the drug, distribution of the drug and metabolism or biotransformation of the drug in the previous class. Now after the metabolism or biotransformation, the next important thing in the pharmacokinetics is the elimination of the drugs, how the drug is eliminated. Now in this elimination, you will read about the different types of the pharmacokinetic parameters. Already in the distribution, you have read about the volume of distribution. In the absorption part, you have read about the bioavailability of a drug. So you know about the bioavailability of a drug, you know about the volume of distribution of a drug. These two are one of the main important pharmacokinetic parameters, and the third one is the clearance of the drug. We will read about this here. So volume of distribution, first is bioavailability, volume of distribution and clearance of the drug. These three pharmacokinetic parameters ultimately determine different other derivative parameters. For example, what is the plasma half-life of a drug? How the drug is eliminated? What will be the dose frequency? How the steady state plasma concentration is reached. So this type of different mathematical models are created from these different types of the parameters, and accordingly we can predict how a drug behaves in our body. Okay. So let's just start with this. First, excretion or elimination mainly occurs most commonly through the kidney. We all know kidney is the excretory organ. Apart from this, it is also excreted through the feces. Most of the drug present in feces is derived from the bile. So drug is secreted in the bile. You have already seen in the biotransformation class, and it undergoes enterohepatic circulation, and then again it is secreted in the bile, and then it comes to the feces. Relatively large molecules drug, for example, whose molecular weight are greater than 300, they are preferentially eliminated in the bile. Certain drugs are excreted directly into the colon, in our colon, okay, like anthracene purgatives, different types of the heavy metals, etc. So through the kidney, through the feces, mainly these two. Apart from this, there are some minor ways by which the drug is eliminated. For example, exhaled air gases or volatile liquids like general anesthetic, alcohol, etc. They are eliminated by lungs irrespective of their lipid solubility. And saliva and sweat, lithium, potassium iodide, rifampicin, heavy metals, these can be excreted through the saliva and sweat. Milk, drug is secreted albeit in the minute quantities in the milk also. That's why in case of the lactating mothers, when we are giving some drugs, we have to keep in mind that drug, whether it is secreted in the milk through the newborn baby or not. If it is secreted, if it has any hampering effect on the newborn baby or not. Accordingly, some drugs cannot be given in the lactating or nursing mothers. Okay. So you can see in the kidney, when the drug comes in the kidney, in the anatomy you have read about there is tubules, there is glomerulus. So this is the glomerular filtrate. Glomerular filtrate contains the drug. This is the Bowman's capsule. Then it comes into the proximal tubule, loop of Henle, distal tubule, collecting duct, and then it is excreted. So in the glomerular filtrate, when it comes to the proximal tubule, there may be some active secretion of the drug. So there are some transporters present within the proximal tubule where some drugs are actively secreted into the tubules also. Some drugs are reabsorbed back to the blood also. This is known as the passive reabsorption from the tubules. Mostly this happens in the distal tubule or collecting tubules. So some part of the drug is filtrated, some drugs are secreted directly from the blood to the tubules, some drugs are reabsorbed back, and ultimately the net amount of the drug that is present in the collecting tubules are excreted out. So different drugs behaves differently. What is the amount of the drug that is excreted out? Again the same thing you can see, arterioles, afferent arteriole and efferent arteriole. So like that wise the hepatic blood flow is important in drug biotransformation. Similarly, the renal blood flow is also important in the excretion of the drugs through the kidney. Glomerulus active drug secretion, some drugs are actively secreted and some drugs are reabsorbed back. So this is the renal drug handling. So the kidney is responsible for excreting all water soluble substances. The amount of drug or its metabolites ultimately present in urine is the sum total of the glomerular filtrate, tubular reabsorption and tubular secretion. That is the net renal excretion. It will be glomerular filtration, amount of the drug that is filtrated in the glomerulus plus tubular excretion or tubular secretion and minus tubular reabsorption. Minus means that some part of the drug that is already in the tubules are reabsorbed back to the blood. So ultimately this is the net renal excretion. Glomerular filtration happens because the glomerular capillaries have pores and they are larger than usual. So all non-protein bound drugs, that is those drugs who are bound to some lipids or hydrophilic drugs or insoluble drugs, they presented to the glomerulus are filtered. But protein bound drugs are usually larger, they are less filtered in the glomerulus. Thus glomerular filtration of a drug depends on its plasma protein binding. So plasma protein binding you have read in the absorption class that this is an important, whether what amount of the drug is active. This plasma protein binding is also important, how much amount of the drug is filtrated through the glomerulus. Then coming to the tubular reabsorption, this occurs by passive diffusion and also depends on lipid solubility and ionization of the drug at the existing urinary pH. Urinary pH, whether it is acidic or alkaline, ultimately determines what amount of the drug is ultimately reabsorbed back or secreted, because ultimately all depends upon the pH value of as well as the pKa value of the drug. Already you have read in the absorption class also how the pH and pKa determine the absorption of the drug. That absorption happens in the upper part, and during the tubular reabsorption the same pH and pKa value also plays. Lipid soluble drugs, that is those drugs who are hydrophobic or lipid soluble, they filtered at the glomerulus, back diffuse in the tubules, as 99% of the glomerular filtrate is reabsorbed, but non-lipid soluble and highly ionized drugs are unable to do. So 100% drugs comes and approximately 99% reabsorb, and this circle ultimately continues and ultimately net amount of the drug is excreted out in case of the lipid soluble drugs. But it is just opposite in case of the hydrophilic drugs. Rate of excretion of such drugs like aminoglycoside antibiotics, quaternary ammonium compounds, they parallel the glomerular filtration rate. Glomerular filtration rate GFR ultimately determines what amount of the drug is filtrated in the glomerulus from the outside. So when in case of the lipid soluble drugs, in case of the drugs who are ionized, they are in most of the cases they are reabsorbed back. So ultimately this depends upon the glomerular filtration rate, how much amount of the drug is filtrated. Changes in urinary pH affects the tubular reabsorption of the drugs that are partially ionized. So partially ionized or unionized drugs ultimately determines how much amount of the drug is reabsorbed or secreted. Like weak bases ionize more and less reabsorbed in acidic urine. So when the urinary pH is acidic, here the weakly bases drugs are ionized more and they are less reabsorbed back to the body. So more drugs are excreted. So weak base, those drugs weak base, they are excreted more in acidic urine and vice versa. So weak acids ionize more and are less reabsorbed in alkaline urine. Just opposite, you can see. So those drugs which are weakly acidic drugs, they ionize more in the alkaline urine. When they are ionized more, they are less reabsorbed back to the body and more excreted in the urine. So this concept is usually utilized when there is poisoning, when we want to get rid of the drug more and more quickly. For example, some drugs which had been poisoned and those are the weakly acidic drugs, we can make the urine more alkaline by giving some alkalinizing agents, so that from the urine, when the drug comes into the kidney and different types of the tubules, the reabsorption of the drug will be less, because the drug will be more ionized in the alkaline urine, because these are the weakly acidic drugs, so that more drugs will be excreted out from the body. So this concept is utilized in case of the poisoning mostly. So the elimination of the drug in poisoning. So urine is alkalinized in barbiturate and salicylate poisoning. For example, salicylate poisoning. Salicylate is a, you can see this is a weakly acidic drug. So when this salicylate poisoning happens, we can give some alkalinizing agent to the patient so that the urine becomes more alkaline. When the urine becomes more alkaline, that weakly acidic drugs will ionize more. They will be less reabsorbed from the different types of the tubules and they will be more excreted out from the body. So it is clear. Elimination of the weak bases like morphine, amphetamine, they can be enhanced by acidifying urine also, just the opposite. But there is a problem with acidifying urine. When we are acidifying urine, there is always chances of some metabolic acidosis. There may be problems in the body. There may be rhabdomyolysis, that is muscle can be broken down and hemoglobin can come out and ultimately that goes to the kidney. So kidney failure can happen. So actually worsen outcomes. So by theory, the same thing can be added, same thing can be done for the weakly basic drugs by acidifying urine. But usually we do not acidify urine because acidifying urine causes metabolic acidosis, rhabdomyolysis, acute renal failure and ultimately that becomes more disastrous. So usually acidifying urine is not done, but alkalinizing urine for weakly acidic drugs are usually done in case of the poisoning cases. So it is clear. Tubular secretion is the active transfer of the organic acids and bases by organic anion transporter and organic cation transporter. So these are the different transporter proteins that are present on the kidney tubules and from these tubules different drugs are secreted. Active tubular secretion happens. In addition, efflux transporters are also there like P-glycoprotein, MRP2, etc. These are also located in the luminal membrane of these proximal tubular cells which also secrete the drugs into the tubules. So active transport of the drug across the tubules reduces the concentration of its free form in the tubular vessels and promotes dissociation of the protein bound drug which then becomes available for secretion. When the drug is protein bound, that drug usually cannot be filtered. Even if it is filtered, it is usually less secreted or less reabsorbed. All these problems happen. So all these drugs becomes more active when it is unbound form, protein unbound form. So ultimately active transport happens mainly in the free form of the drug. So protein binding is basically a hindrance for glomerular filtration of the drug. So already you have seen that some of the drugs are very high protein bound and some of the drugs are very less protein bound. So high protein bound drugs usually that is a hindrance for glomerular filtration. Organic acid transporter, organic anion transporter operates for different types of the drugs. These are examples like penicillin, probenecid, uric acid, salicylates, etc. There are some organic base transporter that operates for thiazide, amiloride, triamterene, etc. So remember there are different transporter protein, organic anion transporter, organic cation transporter that basically acts at the proximal tubules and that secretes drug into the tubules. But mainly it depends on the protein binding of the drug. Highly protein bound drug usually not filtrated in the glomerulus and also not secreted in the tubules. But less protein bound drug are free form but mainly secreted. Drugs utilizing the same active transport also compete with each other. So the same transporter mechanism, there are two drugs are given, they usually compete with each other and some drugs are less excreted and some drugs are more excreted. So this also forms a basis for the drug-drug interaction. For drugs and their metabolites like some exogenous substances also secretion in the tubular lumen happens. So an endogenous substance like uric acid is predominantly reabsorbed. So not only the drugs, different other endogenous substances like uric acid, they are also filtered in the glomerular. Some part is also excreted by the tubular secretion. So this endogenous substance can also compete with the drugs for the same type of the receptor in the glomerular filtrate. For example, probenecid is a drug which is an organic acid and which has high affinity for the tubular organic anion transporter. It blocks the active transport of the both penicillin and uric acid. So penicillin is a drug and uric acid is present in our body. So when this probenecid is given, they compete with both penicillin as well as the uric acid for this organic anion transporter. So the net excretion of the penicillin is decreased. So penicillin cannot be excreted out through the organic anion transporter because probenecid acid mainly blocks that, and probenecid acid is mainly secreted. So, and that of the uric acid is increased because uric acid is also not excreted out. So, more and more uric acid builds within our body, that can lead to hyperuricemia because penicillin is primarily secreted while uric acid is primarily reabsorbed. So, the transporter protein, some drugs or endogenous substance preferentially can be excreted, some drugs or endogenous substance preferentially can be reabsorbed back. So ultimately when we are using some drugs, the net excretion or net reabsorption depends upon what is the predominant mechanism of action of that drug, whether it is more excreted out or whether it is more reabsorbed back. That's why when probenecid is given with some penicillin and also uric acid present in our body, it has been seen probenecid blocks the organic anion transporter. So penicillin is less excreted, so more penicillin availability becomes within our body, and uric acid also less excreted and uric acid concentration increased in our body. Salicylates block uricosuric action of the probenecid and sulfine pyrazone and decrease tubular secretion of the methotrexate. These are examples. Methotrexate is a drug and salicylate is another drug. When these two drugs are given together, salicylate blocks the uricosuric action of the probenecid. That is, probenecid mainly helps in uricosurium, that is blocked, and decreases the tubular secretion of the methotrexate. Just example, probenecid also decreases the concentration of the nitrofurantoin in urine. Example, nitrofurantoin is an antibiotic used in urinary tract infection. So for urinary tract infection treatment, we need more availability of the antibiotic in our urine. So when this probenecid is given, that also decreases the more availability of this nitrofurantoin in the urine. So there will be less action of the nitrofurantoin. That can happen. These are different other examples. So tubular transport mechanisms are not well developed at birth. So in neonates, it is not well developed. As a result, the duration of action of many drugs like penicillin, cephalosporin, aspirin, their action is quite longer in case of the neonates. These systems mature during the infancy when the baby grows. So renal function also progressively declines after age 50. The glomerular filtration rate progressively declines. This is the normal physiological way by which the kidney function ultimately decreases. So renal clearance of the most drug is substantially lower in elderly. This we have to keep in mind. In case of the elderly subject, the renal clearance of the drugs will be less. So we have to adjust the dose accordingly. Now coming to the kinetics of the elimination. So previously I have told that already you have read about the bioavailability and the volume of distribution of the drug. The next important pharmacokinetic parameter is the clearance of the drug. What is this clearance? Clearance is basically a theoretical volume of the plasma from which the drug is eliminated in total in unit amount of the time. So it is a theoretical volume of plasma. So we can assume it is a mathematical model from which the drug is completely removed, completely eliminated in unit time. It is usually calculated at rate of elimination by plasma concentration. So clearance of a drug, in the numerator there is rate of elimination of the drug, and in the denominator there is plasma concentration of the drug. So the clinician usually wants to maintain a steady state concentration of the drug. We want a drug should be in the steady state within the plasma, within a therapeutic window. That is, if it is greater than the therapeutic window, there will be toxicity of the drug. If it is less than the therapeutic window, there will be subtherapeutic effect. That is, no effect will happen. So there will be a window-like phenomenon, therapeutic window, within which the plasma concentration of the drug should be there, so that there will be maximal efficacy and the safety. So knowing the clearance of the drug is useful because its value for a particular drug usually is constant over the range of concentrations encountered clinically, usually. So this is basically true because the metabolizing enzymes and transporters usually are not saturated. So all this clearance happens by different types of the metabolizing enzyme as well as the transporter. Usually these are not saturated, but there are some drugs where the saturation kinetics is seen. And also in many of the commonly used drugs, if it is given in very high doses, ultimately that can saturate the different enzymes or the transporters that are needed for the metabolism or the elimination of the drugs. So now coming to the concept of the first order kinetics and zero order kinetics. So how the drug behaves within our body and eliminated from our body mainly depends on this kinetics. Most of the drugs usually follows the first order pharmacokinetics. What is this first order kinetics? First order means the rate of elimination is directly proportional to the drug concentration. So when the drug concentration is less, rate of elimination of the drug is also less. When the drug concentration is more, the rate of elimination of the drug is also more. So it is directly proportional. Rate of elimination is directly proportional to the drug concentration. So here the clearance remains constant because the clearance already we have seen the rate of elimination by plasma concentration is the clearance. Here the clearance is constant. Basically in first order kinetics a constant fraction of the drug is eliminated in unit time. So in unit time constant fraction of the drug is eliminated. So this applies to majority of the drugs which do not saturate the elimination process. Already we have discussed. Saturation means the transporter or the metabolizing enzyme that is needed for the metabolism or elimination. There will be no such transporter or metabolizing enzyme is present if it is given in very high doses. So clearance can be defined as further as blood clearance, plasma clearance, clearance based on concentration of unbound drug, etc. So in different compartment, usually these parameters are usually we are assuming that it is a one compartment model. That is the drug usually enters and ultimately metabolized and excreted through one type of the system. But when usually in normally the drug usually metabolized by different types of the systems, eliminated also by different types of the system. So it is a multi-compartment model. And accordingly we can assume the clearance for the different other compartments also. But for our convenience usually we assume a one compartment model of our body and assume that this is the clearance of the drug, this is the half-life of the drug, this is the bioavailability of the drug, this is the volume of distribution of the drug. So clearance of the drug by several organs is basically additive. So clearance of a drug through the kidney plus clearance of the drug, some part can be excreted through the lungs also like this. So elimination of the drugs from the systemic circulation may occur as a result of processes that occur in the kidney, liver and other organs. Any significant alteration in the kidney function and hepatic function. So when there is some kidney failure, when there is some hepatic failure, ultimately the clearance will be different. So when the clearance will be different, we have to again adjust the dose. So all this we have discussed about the first order kinetics. So first order pharmacokinetics is basically followed by most of the drugs. Here the rate of elimination is directly proportional to the drug concentration. Here the clearance of the drug is constant and the constant fraction of the drug is eliminated per unit time. This is in contrast to the zero order kinetics. In zero order kinetics, the rate of elimination remains constant irrespective of the drug concentration. So drug concentration may be very high, but the rate of elimination is the same. Drug concentration may be low, but the rate of elimination is the same. In the first order kinetics, the rate of elimination is directly proportional to the concentration of the drug. Here it is not, it is constant. Rate of elimination is constant. And clearance ultimately decreases with increase in concentration. So ultimately clearance decreases. When the clearance will be decreases, there will be more accumulation of the drug within our body. So when we are increasing this type of the drugs which follows the zero order kinetics, there will be more buildup of the drugs in our body. And here you can see the constant amount of the drug is eliminated in unit time. So in the first order kinetics, constant fraction of the drug is eliminated in unit time. In zero order kinetics, constant amount of the drug is eliminated in unit time. We will again discuss. So this is also called capacity limited elimination or Michaelis Menten elimination. Capacity limited or Michaelis Menten elimination. So here the elimination of some drugs approaches saturation over the therapeutic range. Kinetics may change from first order to zero order. So there are some drugs which usually behaves to the first order kinetics. But when we are increasing in very high dose, that can change to the zero order kinetics also. The example is the Phenytoin. Phenytoin is an anti-epileptic drug that can change its behavior from the first order kinetics to the zero order kinetics in high doses. Here plasma concentration increases disproportionately with increase in dose as occurs in Phenytoin, tolbutamide, Theophylline, Warfarin. These are the examples where the drug changes from the first order kinetics to the zero order kinetics with increased dose. Phenytoin is an anti-epileptic drug. Tolbutamide, this is not nowadays used, it is an anti-diabetic drug. Theophylline, anti-asthmatic drug, and Warfarin, it is an anticoagulant. So these drugs behaves like this. So you can see from the graph, so this is the first order kinetics. So this is the relationship, this is the dose rate, this is the average steady state concentration, and zero order kinetics, you can see zero order kinetics is like this when we are plotting. So from this kinetics of the elimination, we can deduce the half-life of the drug also. Half-life means plasma half-life. It is the time taken for its plasma concentration to be reduced to half of its original value. So original concentration is, for example, 100. How much time it comes to the 50? So how much time? This is the plasma T-half. Plasma T-half of a drug is the time taken for its plasma concentration to be reduced to half of its original value. Okay. So our drug which has rapid one compartment distribution and first order kinetics, that follows the first order kinetics, and is given intravenously, a semi-log plasma concentration time plot can be plotted. So like this. So you can see this is the time in hours and this is the plasma concentration of the drug. This is the x-axis, this is the y-axis. So when a drug is given by intravenous route, firstly there will be a rapid reduction. This happens due to the distribution of the drug in different types of the tissues, and then it comes to the elimination. So from this we can deduce two types of the half-life. One is the distribution half-life, another is the elimination half-life. But mostly, in most cases, simply by half-life we means the elimination half-life. We usually do not need any distribution half-lives. So remember, half-life means elimination half-life. So this is the elimination half-life. So you can see this is the time 2468 and this is the plasma concentration. So amount of the drug when it comes to half plasma concentration. So this is the half-life, you can see. So this is the half-life. So the plot has initial rapidly declining the alpha phase due to distribution and the less declined beta phase due to elimination. Already we have seen this is the alpha phase, this is due to the distribution, and this is the beta phase, this is due to the elimination of the drug. So at least two half-lives can be calculated, but mostly we know by half-life we usually means the elimination half-life. So most drugs have multi-compartment distribution, what I have talked, and multi-exponential decay of plasma concentration time plot. So you can see this is a exponential equation. So ultimately this will not touch, but it will touch in exponentially. Half-lives calculated from the terminal slopes when plasma concentrations are very low are exceptionally long, probably due to release of the drug from slow equilibrating tissues, enterohepatic circulation, etc. So what happens at the last? It is released from the tissues in the deeper tissues when it is already there. So ultimately it takes time. So that's why it is an exponential equation. In the calculus you have read about the exponentiality. So it is an exponential equation. It ultimately does not touch here, just slopes like this. So only the T-half calculated over the steady state plasma concentration range is clinically relevant. So this is the steady state in the plasma, and after that there will be slopes. So here is usually the plasma T-half is usually calculated in the steady state plasma concentration. So mathematically this T-half is calculated as the ln T by K. Ln is logarithmic scale. In the logarithmic scale you have read in the mathematics in the class 12, 11, 12. So opposite of the log 2 is the ln. So ln 2 by K. So ln 2 is the natural logarithm of 2, and this is calculated as the 0.693. So this T-half of the half-life is basically ln 2 by K. Ln 2 is the 0.693, and what is this K? K is the elimination rate constant of the drug, and this elimination rate constant of the drug is different for different drugs. So what happens? This elimination rate constant is basically calculated as clearance by volume of distribution. So we know for a drug that this is the clearance of the drug, and for this is the volume of distribution of a drug. From this we can calculate the elimination rate constant by clearance by volume of distribution. Okay. So therefore T-half, so T-half is the ln 2 by K. Ln 2 is the 0.693. So ultimately it will be T-half will be 0.693 into volume of distribution by clearance. So this is the formula. So how we can calculate a plasma half-life of a drug when the clearance of a drug and volume of distribution of a drug is given? So there may be a problem is given that this is, for example, this is the paracetamol whose volume of distribution is this, clearance of a drug is this. So what is the plasma half-life of the drug? So plasma half-life of the drug is the 0.693 into volume of distribution to be divided by the clearance of the drug. Now, what amount of the half-life is usually needed for a near total complete elimination of the drug? So, for a first order kinetics we are discussing, for the first T-half 50% drug is eliminated, okay. So, the next T-half 50% remains in our body, from this 50% also 50% is eliminated. So, 50% of 50% is 25%. So, ultimately 50 plus 25, 75% drug is eliminated, because already we have seen that constant fraction of the drug is eliminated in unit time in first order kinetics, constant fraction, okay. So, constant fraction, that fraction may be 50%. For example, for this drug 50%, this is the constant fraction that is eliminated in unit time. So, for one T-half 50% is eliminated, for the second T-half 50% plus 50% of the 50%, that is 25%, total 75% drug is eliminated. Similarly, in the third T-half 50% plus 25%, again 50% of 25, that is the 12.5, that is 87.5% drug is eliminated. It is clear? After the fourth T-half 50 plus 25 plus 12.5, 50% of the 12.5 is the 6.25. So, if we can calculate all this, that is 93.75% drug is eliminated. So, after the fifth T-half 6.25, 50% of the 6.25 will be 3.125. So, we can calculate 50 plus 25 plus 12.5 plus 6.25 plus 3.125. So, it approximately counts approximately 97 or 98%. So, we can say after approximately 4 to 5 half-lives, most of the drug is eliminated from our body. So, it is clear, you can see after 40 half approximately 94% is cleared, and approximately half-life approximately 97 or 98% is cleared. And already in the first order kinetics we have seen that this is an exponential equation. So, ultimately it will not come to the zero at once. So, ultimately it likes a slope. So, we can say after approximately 4 or 5 half-lives, near total elimination of the drug happens. So, for example, one drug half-life is 2 hours. So, we can predict that after 10 hours, after 8 to 10 hours, total drug, most of the drug is eliminated from our body. Again, we can give the next dose after 10 hours, like this. This is in very simplistic term. So, by which this usually plays in case of the first order kinetics. So, here you can see first order kinetics, T half is the constant. So, plasma half-life is constant in because of the first order kinetics, because the volume of distribution and clearance do not change with dose. With dose, volume of distribution do not change, clearance do not change, constant fraction of the drug is eliminated. This is all in the first order kinetics. Most of the drug follows the first order kinetics. But in case of the zero order kinetics, we cannot predict this T half, because the T half ultimately becomes prolonged, because the clearance will be lesser. So, zero order kinetics T half increases with dose, because the clearance progressively decreases as dose is increased. For example, here the 50% here for drug A, which follows the first order kinetics, we are assuming here in this equation 50% drug is eliminated in one half-life, and accordingly this calculation is done. Now, calculate for a drug in a zero order kinetics. Similarly, for a zero order kinetics, constant amount of the drug is eliminated for per unit time. Similarly, for one T half, for 100 milligram drug, you can assume 50 milligram is eliminated. So, after the first T half, 50 milligram drug is eliminated. So, after second T half, this is not 75%, that is, this is not 50% drug is eliminated. So, the constant amount of the drug is eliminated. So, that is why ultimately it becomes prolonged, it comes on prolonging, clearance ultimately decreases, T half ultimately increases. So, there is always chances of the poisoning for the drugs which follows the zero order kinetics, or for those drugs which ultimately changes from the first order to zero order kinetics when high dose is given. So this is clear. So this is clear how this is calculated. Mostly this calculation is done in the first order kinetics. So half-life is calculated as 0.693 into volume of distribution by clearance. 0.693 is basically the ln 2 logarithmic, natural logarithm of 2, and this elimination constant is basically comes from the clearance by volume of distribution. So ultimately it changes. So T half is the 0.693 into volume of distribution by clearance. So this formula and this concept is very important. Okay. So now when a drug is repeated at relatively short intervals, খুব কম interval if we are repeating a drug, it accumulates in the body until elimination balances the input and a steady state plasma concentration is attained. So ultimately by this first order kinetics, 50% eliminated, ultimately a time will come when there will be a steady state plasma concentration will be reached. So this is known as the Cpss or steady state plasma concentration. This is calculated by dose rate by clearance. Dose rate. What is the rate by which we are giving the dose of the drug, and it is divided by the clearance of the drug. So from this equation, it is implied that doubling the dose rate would double the average steady state plasma concentration. So if we are increasing the dose rate, for example, some drug we are giving twice daily, and the same drug we are giving in another individual 4 times daily. So ultimately the steady state plasma concentration will be higher, 2 times higher for the first order kinetics drugs. If the therapeutic plasma concentration of the drug has been worked out and the clearance is known, the dose rate needed to achieve the target steady state plasma concentration can be determined. So from this we can determine the dose rate. So ultimately we want to know the dose rate. What will be the frequency of the dose that we need to give to a person so that a drug will reach a steady state plasma concentration in the blood, so that there will be maximal efficacy and the safety. So this can be calculated as the target steady state plasma concentration multiplied by the clearance. So this is already calculated, that is this is the target steady state plasma concentration, this is needed. There are some drugs whose already we have discussed about the therapeutic window. Some drugs, the therapeutic window is very narrow. So if we are changing this steady state plasma concentration very high, there may be toxicity, very low, there will be no effect. So already steady state plasma concentration we know, and we know about the clearance of the drug, then we can multiply this to determine the dose rate like this. So for example, you can see, so this is the start of the drug infusion. For example, we are giving an intravenous infusion of the drug. So first, when there is intravenous infusion of the drug is given, there will be rapid rise of the concentration of the drug in the plasma. Okay. Now here the drug infusion is stopped and the washout begins. When the drug infusion is stopped, there will be first drastically reduced, and then there will be some steady state plasma concentration achieved, and then it comes to the plateau, and ultimately it will be an exponential once. So ultimately from this we can determine what will be the half-life of the drugs, what will be the dose range of the drug. Now if we want that the drug will remain in our body in this level, for example in the 50 level, we can determine from this T half that in which time we have to again inject the drug. For example, when the drug is here, we have to again infuse the drug so that it will be increased from here. So by this the dosing of the drug, frequency of the dosing of the drug is determined from the half-life of the drug, volume of distribution of the drug, as well as the clearance of the drug. So a faster rate of the infusion does not change the time needed to achieve the steady state, only the steady state concentration is changes. So when we are giving a low rate of infusion, the lower ones, this is in contrast to the high rate of infusion. When we are giving in high rate of infusion, that achieves the steady state plasma concentration that can be earlier. So ultimately it does not change the time needed, but only the steady state concentration can be changed. So the time will be same, but the steady state plasma concentration is higher when is given low rate in comparison to the high rate. Now if for a drug we want more concentration of the drug in our body, we can increase the dose. If we want less concentration of the drug in the body, we can decrease the dose like this. But ultimately we can see the steady state plasma concentration reached, the time is same because the plasma half-life of that drug is same. Plasma half-life is same, the same time, but if we give very high rate of the drug, ultimately the concentration of the drug in our body will be increased, but in the same time period. Okay. Now coming to the repeated drug administration. So after oral administration, these examples are given by intravenous infusion because it is easier to understand. Intravenous means we are directly injecting a drug to the blood so that there will be no first pass metabolism. But mostly we are taking some drugs orally. When we are taking some drugs orally, some part of drug is available to the body for absorption. So this can be calculated from the bioavailability. Already we have read. So that bioavailability is the fraction that can be calculated as the F. So only a fraction of the drug reaches the systemic circulation in the active form. So here the dose rate is the target steady state plasma concentration in the blood has to be divided by this bioavailability, this F, that is that fraction that reaches the target, that is the active part of the drug that is needed for its action. So this dose rate and target plasma concentration relationship is linear only in case of the drugs eliminated by the first order kinetics. So all this we have discussed are for the first order kinetics where there is linear relationship, but for the zero order kinetics we cannot predict anything because for the zero order kinetics the drug will behave erratically. So how much amount of the clearance will decrease, how much amount of the half-life will increase of the drug in case of the zero order kinetics we cannot predict. So there will be always chances of some poisoning. So this happens, zero order kinetics is mostly followed by the ethyl alcohol. Zero order kinetics from the first it is followed by the ethyl alcohol, and there are some drugs like Phenytoin, Warfarin, these tolbutamide, ultimately they changes from the first order to the zero order when it is given in higher doses. So when it is higher doses we cannot predict. So all this will fail. So increase in their dose beyond saturation level causes an increase in the concentration which is out of proportion to the change in dose rate. So we cannot predict the dose we are giving and the plasma concentration that is achieving. There will be no relation for when the saturation kinetics comes into play. Rate of drug elimination is basically the Vmax into the concentration by Km plus concentration. So this C is the plasma concentration of the drug, Vmax is the maximum rate of the drug elimination, Km is the plasma concentration at which the elimination rate is half maximum. This equation is not very important, but the previous ones are very important. This is more complex and there are more complex equations, more complex particularly in case of the multi-compartment model are usually analyzed when a drug pharmacokinetic study of the drug is done. So when a drug, for example a new drug, when it has to be marketed, when it comes to the market for first human consumption, before it this type of the pharmacokinetic studies are also carried out. It are to be seen what amount of the drug is to be given, at which frequency of the drugs has to be given, and accordingly it is to be adjusted. So it will be a complex one, but these ones are the important. How the steady state plasma concentration, what is the concept of the first order kinetics. So this is clear, this is the concept of the first order kinetics, just opposite is the zero order kinetics where a constant amount of the drug is eliminated per unit time, constant amount. For example 100 milligram drug is injected, now only 25 milligram is eliminated, constant amount. So 100 it is eliminated 25, that is 75 is remaining, again from the 75 only 25 is remaining. So ultimately we can see after 4 to 5 half-lives more amount of the drug remains within our body in comparison to the first order kinetics. You can calculate yourself. So 25% in one hand, only 25 milligram in another hand. After 4 to 5 lives you can see in case of the first order kinetics approximately 90, 97 or 98% drug is eliminated, but in case of the zero order kinetics it will be approximately 70% or 75%. So this is just for a assumption. So zero order kinetics, here remember the difference between the first order kinetics and zero order kinetics. This is very important for your exam purpose in your future practices also. First order kinetics, most of the drug follows, which is basically constant fraction of the drug is eliminated per unit time. In zero order kinetics, constant amount of the drug is eliminated per unit time. In first order kinetics, clearance is constant throughout. In case of the zero order kinetics, clearance gradually decreases. In case of the first order kinetics, half-life of the drug is constant. In case of the zero order kinetics, half-life of the drug progressively becomes increased. More half-lives. Clearance decreases, half-life increased in zero order kinetics. So it is clear? So you can see here the different drugs are given in different time periods. So first drug is given by the infusion. So here the drug in infusion is given, ultimately that will be decreased, again another dose of the drug is given here, another drug is given here, another drug is given here, like this. And here if we are giving less amount of the drug, there will be less amount reached in the plasma drug concentration. So how the drug is given? Like this. So this is known as the Plateau principle. How the Plateau is reached? When constant dose of a drug is repeated before the expiry of a 4 T-hub, 4 or 5 T-hub, we normally assume that most of the drug is eliminated, it would achieve higher peak concentration. So before 4 T-hub, if we are again giving the drug, ultimately that reaches the higher drug concentration. Already we have discussed, because some remnant of the previous drug are already present in our body. So this continues with every dose until progressively increasing rate of elimination balances the amount administered over the dose interval. So when it will be increased for first order kinetic drug, usually the rate of elimination also increased. So ultimately always it tries to balance, and ultimately the Plateau principle will be reached. But again, if the dose is very high, that increased drug elimination will not happen, because there may be saturation of that enzyme or transporter protein, and then saturation kinetics will come. So plasma concentration ultimately plateaus and fluctuates about an average steady state level. So this is known as the Plateau principle of the drug accumulation. So ultimately there will happens after 4 half-lives, 5 half-lives, there will be a Plateau principle. So steady state is reached in 4 to 5 half-lives unless dose interval is very much longer than the T-hub. So usually in normal administration of the drug, we can assume that Plateau, normal or steady state plasma concentration can be reached after 4 to 5 half-lives of the drugs. So you can see here the drug is given repeatedly, and ultimately this happens, it is the Plateau principle. Ultimately it comes to the Plateau, a straight line like this. So ultimately it will be continued if we are continuing giving the drug. If we stop giving drug, ultimately it will be dropped, and again it will be an exponential decay. Okay. So this is known as the target level strategy for drugs whose effects are not easily quantifiable and safety margin is not big. There are some drugs we can quantify its effect. For example, anti-hypertensive drugs. So we can measure the hypertension, we can measure the blood pressure, and we can increase or decrease the dose of the drug if the blood pressure is not controlled. But there are some drugs whose outcome cannot be easily quantified. For example, some anti-epileptic drug, some antidepressant drug, some anti-manic drug. Here, whether the drug is achieving its target concentration, that can be achieved by measuring their plasma concentration, and this can be done by means of a parameter. This is known as the therapeutic drug monitoring. So we can monitor the plasma concentration of the drug by the therapeutic drug monitoring system, TDM system. This is usually done by the HPLC method, high pressure liquid chromatography, and accordingly we can increase or decrease the dose of the drug. So for example, this anticonvulsant, antidepressant, there may be some antimicrobials also. So drugs who have very short T-hub up to 2 to 3 hours administered at conventional interval, for example 6 to 12 hourly, achieve target levels only intermittently, and fluctuations in plasma concentrations are marked. So here we have to give much frequent dosing of the drug, otherwise there will be increase of the dose of the drug and then again decrease. Again we have to give the drug, again increase, again decrease. Okay, this may happen. Similarly, for drugs with very longer T-hub, a dose that is sufficient to attain the target concentration after single administration, if repeated, will accumulate according to Plateau principle and produce toxicity later on. Again, for a long T-hub drug, if we are giving this drug repeatedly, there may be accumulation and there may be toxicity. So this is problem with the very short T-hub drug, very high T-half drug also in both of the drug. So if the dosing is such as to attain target level at steady state, the therapeutic effect will be delayed by about 4 half-lives. Such drugs are often administered by initial loading and subsequent maintenance doses. So what happens for a very short T-half drugs or very long T-half drugs? Now we want a steady state plasma concentration quicker. For example, there may be some septicemia. We want a quicker concentration of the drug so that the bacteria will be killed. Or there may be some heart attack, or there may be some stroke. We need some drugs so that the thrombus will be lysed. So here we have to give some drugs. Firstly, a large amount of the drug is given. This is known as the loading dose, and then we have to maintain the dose by means of the maintenance dose. So this is the concept of the loading dose and maintenance dose. So what is the loading dose? This is the single or few quickly repeated doses given in the beginning to attain the target concentration rapidly. Because here we want the target concentration rapidly to achieve. The half-life may be very small or half-life may be very large in these cases. So it may be calculated as loading dose is target plasma concentration into volume of distribution, and F is the fraction of the drug that is absorbed. So that may be the bioavailability. So here the loading dose is mainly governed only by the volume of distribution and not by the clearance or the half-life of the drug. So volume of distribution mainly determine the loading dose of the drug. So loading dose is target plasma concentration. We know that this target is needed for a effective dose of the drug, and we need quickly. Right now we need. So we have to inject large amount of the drug. What amount have to inject? That is calculated by the target plasma concentration into volume of distribution, and F is the fraction that is needed for the oral drug or others. So basically this depends upon the volume of distribution of the drug, but it does not depend upon the clearance of the drug or half-life of the drug. We do not need to know about the clearance or half-life of the drug. We need to know about the clearance and half-life of the drug in case of the maintenance dose. So after the loading dose of the drug, we have to maintain the dose so that there will be target plasma concentration is continuation of the target plasma concentration, and that is basically governed by the half-life of the drug as well as the clearance of the drug. So this dose, what is the maintenance dose? It is to be repeated at specified interval. So we need to know about the interval by the different types of the equations already you have seen. After the attainment of the target plasma concentration, so as to maintain the same by balancing the elimination. So first we are giving large amount of the drug by means of the loading dose. Loading dose is calculated by the target plasma concentration multiplied by the volume of distribution. This depends upon the volume of distribution of the drug. Now the drug reaches the plasma concentration. Now what will be the dose of the drug and what will be the frequency of that dose of the drug? That is usually governed by the clearance of the drug and the half-life of the drug, and this is known as the maintenance dose of the drug. Okay. So maintenance dose is governed by the clearance or half-life of the drug. If facilities for the measurement of the drug concentration are available, measurement of the drug concentration is done by, already I have said, by therapeutic drug monitoring, TDM method, and this is done in the laboratory by means of the high pressure liquid chromatography, HPLC. So attainment of target level in a patient can be verified subsequently and dose rate adjusted if required. So such two-phase dosing ultimately provides rapid therapeutic effect, immediate effect, rapid therapeutic effect can be attained with long-term safety, frequently applied to digoxin. Digoxin is given in case of the heart failure. Chloroquine, antimalarial drug, you know there is first loading dose is given so that the parasites will be killed, and then maintenance dose is continued. Frequently applied to digoxin, chloroquine, long-acting sulfonamides, this is antibiotic. Doxycycline is another antibiotic. Amiodarone, it is given in some types of the arrhythmia also. Supraventricular arrhythmia, SVT. Here the amiodarone injection, first loading dose is given and then maintenance dose is given. So remember, for these drugs usually two-phase dosing is given, loading dose and maintenance dose. Dosing regimen, however there is no urgency, maintenance doses can be given from the beginning. The concept of the loading and maintenance dose is valid also for short T-half drugs and IV administration in critically ill patients. Already we have discussed very short T-half drug, very long T-half of the drug in critically ill patients. For example, lidocaine or amiodarone, it is used for cardiac arrhythmia. given first as IV bolus dose followed by slow IV infusion or intermittent fractional dosing. First loading dose is given and then maintenance dose is given. So you can see this is the repeated fixed dose. If we are giving some repeated fixed dose, ultimately it achieves a steady state plasma concentration. But when we are giving a single fixed dose, even if it is high dose, ultimately it will be drops and ultimately that will plateaus, exponentially plateaus, so that there will be no therapeutic effect. So that's why we have to give the repeated fixed dose, maintenance dose we have to give. So significance of the plasma T-hub, frequency of the administration of a drug is dependent on it. What will be the frequency of the drug in all of the cases, whether the normal drug administration, whether it is the maintenance dose after the loading dose, all this depends upon the plasma T-hub. If a drug has long T-hub, then it takes much longer time to achieve the steady state plasma concentration, and thus this is one of the reasons for using loading dose of a drug. If a drug has short T-hub but there is emergency, even then the drug is used as a loading dose. Already we have discussed short T-hub but emergency we have to use the loading dose of the drug. Example, lignocaine or lidocaine in cardiac arrhythmia. The drug whose T-hub is more than 24 hours, more than 1 day and administered daily, they ultimately accumulate on prolonged daily use and may lead to toxicity. So based only that amount to be given every day, which is eliminated daily after achieving steady state plasma concentration in plasma. So there may be some drugs whose plasma half-life is very high, greater than 1 day. So here we have to calculate how much amount of drug of the eliminated per day, and that amount is to be substituted every day. So that ultimately after 4 to 5 half-lives, a steady state plasma concentration is reached. So for these drugs also it is given per day, but the amount of the drug is calculated for this from the T-hub. If reduced clearance due to any reason, T-hub is prolonged. Already we know. Exception of it is not guiding factor for dosage schedule determination. Where the T-hub we cannot, ultimately it will be a guiding factor for a drug administration. Where we cannot take the help of the half-life of the drug. In case of the hit and run drugs means the drug hits a target, ultimately drug is eliminated in due course, in due time. But the action of the drug is prolonged for a longer period of time. For example, the drug blocks some enzymes. That enzyme needs to be synthesized for a long period of time for its fresh action. Example, reserpine. Drugs generating some active metabolite. Here the drug is eliminated but its active metabolite is also active. So here the T-hub will be of no use. Example, benzodiazepines. Of course, drugs with zero order kinetics, already we have discussed. Those drugs who follows the zero order pharmacokinetics we cannot predict from their T-hub. Example, phenytoin, that changes from first order to zero order. The plasma half-life may be altered in impaired hepatic or renal function. When there is hepatic failure or renal failure, there may be problems depending on route of elimination. So we can summarize, most drugs unless highly bound to plasma protein cross the glomerular filter freely. Remember, many drugs, especially weak acids and weak bases, are actively secreted in the renal tubules because this depends upon the pK of the drugs and pH of the tubular fluid. Lipid soluble drugs are passively reabsorbed by diffusion across the tubules, so are not efficiently excreted in the urine. Because of this pH partition, weak acids are more rapidly excreted in alkaline urine and vice versa. Already we have seen why urine alkalinization is needed for poisoning of the drugs who are weakly acidic. Next is, most drugs unless highly bound to plasma protein cross the glomerular filter freely. Many drugs, especially weak acids and weak bases, are actively secreted into the renal tubules and thus more rapidly excreted. Remember, lipid soluble drugs are passively reabsorbed by diffusion across the tubules, so they are not efficiently excreted in the urine because they are reabsorbed back, because they are lipid soluble, and our lipoprotein membranes are the lipid soluble. Because of this pH partition, weak acids are more rapidly excreted in alkaline urine. Already we have seen. Several important drugs are removed predominantly by renal excretion, and again they may be seen to toxicity in case of the elderly person, because in elderly the renal function gradually decreases. Total clearance, ultimately clearance in different compartments. So ultimately in the realistic attitude, the drugs is eliminated from different areas and clearance is summation of clearance from different areas. So clearance determines the steady state plasma concentration. We already know. For many drugs, disappearance from the plasma follows an approximately exponential time course, exponentiality ultimately. Volume of distribution is an apparent volume linking the amount of the drug in the body at any time to the plasma concentration. Volume of distribution, what is volume of distribution is very important, already you have read in the distribution part. Half-life or elimination half-life, very important, everything about the half-life. Repeated dosing, how the repeated dosing is needed to reach the steady state plasma concentration. In urgent situations, how the loading dose is given, how it is followed by the maintenance dose. There are different compartment models, already we have seen alpha phase, beta phase, distribution half-life, elimination half-life. Mostly half-life we means the elimination half-lives, okay. Some drugs may show non-exponential saturation kinetics or zero order kinetics where we cannot predict. So, knowledge of the kinetics enables rational dose adjustment. What will be the utilization of all these pharmacokinetics for rational dosing of the drug? For example, the dose interval of a drug such as gentamicin eliminated by renal excretion may need to be markedly increased in patients with renal failure. The dose increment needs to achieve a target plasma concentration range of a drug such as phenytoin is much less than for a drug with linear kinetics, because phenytoin follows the zero order kinetics when it is given in higher doses. So, approximate T-half of a drug can be very useful even if a therapeutic concentration is not known. So, in correctly interpreting the adverse events that occur some considerable time after starting regular treatment. So, we can predict that some adverse effect can happen after this. So, in deciding on the need or otherwise for an initial loading dose when starting treatment with drugs such as digoxin, amiodarone. These drugs repeatedly I am telling because this digoxin, amiodarone, they needs the loading dose, they needs the maintenance dose. The volume of distribution of a drug determines the loading dose and the clearance and the half-life is needed for determining the maintenance dose. So, this is all about the pharmacokinetics elimination part. This is very complex and I have given you everything. Just read in the evening so that it will be easy. So, you have to read about the first order kinetics and zero order kinetics. If your concept is clear about what is first order kinetics and what is the zero order kinetics, everything will be clear. So, I have time and again tries to make you understand about this first order kinetics of the drug and zero order kinetics of the drug, and from this the clearance, the half-life of the drug, the volume of distribution of the drug, all these are very important in the theory as well as in the viva. And how the calculation is done, mostly the plasma half-life is calculated, how it is calculated when the volume of distribution clearance of the drug is given, and again the short notes, everything can come from the loading dose as well as the maintenance dose.